Okay, so features we have covered so far: outer cannula, inner cannula, obturator, cuff, balloon. So be sure that you're solid on the structure and function of all these tracheostomy tube features, because we are going to keep adding and exploring features of tracheostomy tubes, and it'll get more complicated moving forward. Also, let me mention that you'll see that the sides of the outer cannula have these little holes, which are points of attachment for a strap, which wraps around the neck, as you can see here in this image. That is to hold the tracheostomy tube in place because the patient's going to be doing a lot of coughing. And if that strap is not in place, when they cough, basically they would just shoot the tracheostomy tube out of their stoma. So the next feature we're going to talk about on some tracheostomy tubes is the presence of fenestration. And that is a little window there. And so we will refer to tracheostomy tubes as being fenestrated or unfenestrated. And the outer cannula can be fenestrated, the inner cannula can be fenestrated, or the outer cannula alone can be fenestrated. And you can see, looking at these two images, that a fenestration is essentially just a window. It is a hole in the inner or outer cannula, or both, depending on the needs of the patient. But if we just talk about the presence of the fenestration in the outer cannula, as in this image or down here, you can see that having that hole there allows the inspiratory or expiratory airflow to pass more easily through the natural airway. So if this patient in this image goes to exhale, you can see that air can pass through the bottom of the trach and then out through the fenestration up between the vocal folds. The expiratory air might pass around the outer cannula entirely, as in here, or it might pass out of the tracheostomy tube. So in the case of a fenestrated outer cannula, you could have an inner cannula that is not fenestrated. And when it is placed in, then the air is going to be directed much more strongly in and out of the tracheostomy tube. And there's not going to be a lot of air passing around the outer cannula up through the vocal folds. If the cuff was inflated, there would be zero air passing around the outer cannula up between the vocal folds on expiration. So this person would not be able to phonate very well. Let's say the patient wants to speak. He could pull the inner cannula out, and that would free air, expiratory air, to pass out of the fenestration up into the vocal folds. So as it says here, it is rare for a cuffed tracheostomy tube to have a fenestration, because usually the cuffed tracheostomy tubes are being used on patients that need ventilator support. And if you need ventilator support, the last thing you want is the inspiratory air being pushed into the tracheostomy tube from the ventilator to not get below the cuff, but to be redirected through the fenestration out through the mouth. And a few slides ago, I mentioned how the doctors may decrease the diameter of the tracheostomy tubes, slowly weaning the patient off of the need for having the tracheostomy tube. So as the diameter gets smaller, there's more emphasis that the patient has to place on breathing through their natural airway versus their artificial airway. The presence of a fenestration also allows that to happen. The docs can use the presence of the fenestration and have the patient pull out the inner cannula and breathe through their natural airway. And we can't really go any further without talking about the tracheostomy cap. So the tracheostomy cap is essentially exactly what it sounds like. I don't have one here, but it is, and all trachs come with them. It's essentially the cover that pops on and it completely occludes the tracheostomy tube. So let's look at this image real quick and start thinking about capped versus uncapped tracheostomy tubes. So this guy has an inflated cuff. There's no fenestration. So if you went in and capped that tracheostomy tube, there would be no air going in and out from his lungs. So he would die pretty promptly. You would be sealing off his airway. Now let's say you deflate the cuff. So here's our deflated cuff. And then you capped the tracheostomy tube. Now zero air will be coming in and out of the tracheostomy tube, but you deflated the cuff. So this will allow inspiratory and expiratory air to squeak through above and below, hopefully past the deflated cuff. But no one is going to be able to breathe very well past a deflated cuff. So let's put a fenestration on this tracheostomy tube. And let's deflate his cuff. And now let's put a cap on the tracheostomy tube. Now air is going to be, inspiratory and expiratory air is going to be moving past the sides of the tracheostomy tube, as well as through the fenestration. So air is going to be moving around the sides as well as up and down through the fenestration. But it will not be going in and out of the tracheostomy tube because that has been capped. Okay, so let's say we keep the cuff inflated. We give this guy a fenestrated tube. And looking at him at this point, so air is going to be moving. Inspiratory air is going to be coming in through the tracheostomy tube down into the lungs, but inspiratory air is also going to be able to move through the natural airway down through the fenestration into the lungs. And expiratory airflow is also going to be able to move up from the trachea out through the tracheostomy tube, as well as through the tracheostomy tube out through the fenestration through the natural airway. And if we gave him a fenestration and left the cuff inflated and then capped the tracheostomy tube, then we're forcing him to breathe inspiration and expiration to be happening through the tracheostomy and through the bottom of the tracheostomy tube through the fenestration. And that's probably not a very comfortable way to breathe. Now, much of this is for illustrative purposes because, as I already mentioned, for the most part, if a patient has a cuffed tracheostomy tube, they're going to be on a ventilator. And those guys will probably not have fenestrated outer cannulas. And if they are, they're not going to be using them probably. Okay, so now we've covered obturator, inner cannula, outer cannula, cuff, balloon, fenestration, fenestrated and non-fenestrated. So there's a lot of features. We're almost done adding the features here. Before we go any further, let's acknowledge the problems that a tracheostomy can produce in the realm of swallowing. As we already mentioned, one of the big problems is the anchoring of the larynx, which reduces hyolaryngeal excursion. Another negative impact that the tracheostomy tubes have on swallowing is that they reduce subglottal air pressure during a swallow. So during a normal swallow, your vocal folds come together and you have a certain amount of air in your lungs that you're holding there beneath the vocal folds, and this creates a certain degree of positive subglottal air pressure. And having that normal levels of positive subglottal air pressure during the pharyngeal swallow facilitates the pharyngeal swallow, facilitates the movement of the bolus through the pharynx. So research has shown that the lower levels of subglottal air pressure that are present when the tracheostomy tube is present increases the length of the pharyngeal stage of the swallow. And of course, you don't want to increase the length of the pharyngeal stage of the swallow because that means that's more time for the bolus to be hanging out over the airway. And also with the lack of airflow passing through the oral, pharyngeal, and nasal cavities, you have a less sensitive pharynx, you have less sensitive larynx, and that's going to mean less bolus control and a reduced cough reflex, which both have negative implications for maintaining a safe swallow. All right, now let's add the last feature that we're going to talk about to tracheostomy tubes, and that is the speaking valve. The most common speaking valve is called the Passy-Muir valve, and essentially what the speaking valves do is that they hook on to the end of the tracheostomy tube. And there's a little valve in there, and the valve allows for inspiratory air to pass into the tracheostomy tube so you can breathe in, but then the valve closes and that directs air not through the valve. It has to go somewhere else on expiration. So that means it's going to pass around the tracheostomy tube through the fenestration, through the natural airway, allowing for phonation to happen, also allowing for appropriate subglottal air pressure during a swallow.
The Passy-Muir tracheostomy and ventilator swallowing and speaking valves incorporate a unique patented design feature that translates into significant benefits which are exclusive to the biased closed position no-leak design. To understand the principle behind the Passy-Muir patented feature, it is important to first understand how an open position valve operates. An open position valve uses a membrane or diaphragm to perform the valve opening and closing functions. The membrane flexes during inhalation, which allows air to pass around it and through the tracheostomy tube. When the inhalation cycle reaches its peak, the membrane temporarily relaxes and returns to its normal position. At this point, the valve is not actually closed. Reversed airflow, which is produced by exhaling, is necessary to force the membrane against the valve body to produce a seal. Before the membrane actually closes, there is a short time lapse where some exhaled air can escape. In addition, some common breathing patterns create an airflow phenomenon that can cause the membrane to vibrate or oscillate, which prevents it from completely sealing, resulting in noise as air leaks out. The open position valve allows secretions to travel up the tracheostomy tube and potentially occlude the tracheostomy tube in the valve. The Passey-Muir valve has a patented feature that virtually eliminates the possibility of these kinds of problems. This feature creates a closed position, no leak condition. The membrane's outer perimeter is forced to normally be in a state of compression against a lip inside the valve body. In a relaxed state, the valve is completely sealed, not requiring reversed airflow to close it. When inhalation begins, the membrane easily bends out of the way to allow air passage with minimal resistance. When the inhalation cycle reaches its peak, air stops flowing and the membrane instantly returns to its normal fully sealed position. This is the closed position no leak feature. As exhalation begins, the valve is already closed, and air immediately follows the path of least resistance up through the trachea and past the vocal folds, exiting through the nasal cavity and mouth. Because the valve closes at peak inhalation, a column of air remains in the tracheostomy tube at all times, creating resistance to secretions entering the tracheostomy tube and the valve.
So for those patients that can handle it, the Passey-Muir valve or any speaking valve is a very positive thing. It allows them to phonate on expiration. The speaking valves allow for the patient to have some degree of cough reflex, some degree of being able to cough and clear the secretions, especially secretions that may be building up around their tracheostomy tube. And this has a big impact on quality of life. Just the patient being able to speak alone is a big deal. All right, so let's go through some different configurations that we have here illustrated. So looking at this first image, we have a non-fenestrated cuffed tracheostomy tube. So you can see here that inspiratory and expiratory airflow is going to have one pathway in and out of the body, and that would be the tracheostomy tube. That would be the artificial airway. The cuff is going to be preventing airflow, inspiratory or expiratory, from going through the natural airway. Now switching over to this image, we have deflated the cuff and there is no fenestration. So you can see that this patient can inspire or expire past the deflated cuff and in and out of the tracheostomy tube. Now once again, if we talking about the cap, if we capped this guy here, we're going to be sealing off his airway entirely. So that would be a bad thing. If you capped this person here, they're still going to have some ability to respirate past the deflated cuff, although that may as well be very well compromised. So anytime you put a cap on the patient's tracheostomy tube, you have to be on high alert as to what is going on. And usually capping the tracheostomy tube is only something that happens once they get to the point where you're trying to help them wean themselves off of dependency on the tracheostomy tube. All right, so looking at this individual, we have a non-fenestrated cuffed tracheostomy tube with a speaking valve in place, and we have the cuff deflated. So in this scenario, inspiratory air is going to be able to pass down through the natural airway and around the deflated cuff, and inspiratory air is going to be able to pass into the speaking valve and down into the lungs. And expiratory airflow is going to be able to pass up around the deflated cuff and out the natural airway. But with the speaking valve present, it is not going to be able to pass through the tracheostomy tube. The speaking valve only allows for inspiratory air to pass into the tracheostomy tube. So no air is going to go, no expiratory air is going to pass out through the tracheostomy tube. It's all going to be directed up between the vocal folds, allowing phonation to happen. All right, here we have a fenestrated and cuffed tracheostomy tube, but the inner cannula is non-fenestrated. So with the inner cannula being not fenestrated and the cuff inflated, the only way air is going to pass in and out of the body is through the tracheostomy tube. The air has no path to get around the cuff or through the fenestrated outer cannula into the natural airway. So for this individual, phonation is not going to be possible. All right, now let's look at this individual over here. You have a cuffed tracheostomy tube with a fenestrated inner and outer cannula, and you have the speaking valve placed. So for this individual, inspiratory air, it's going to come through the speaking valve, and with the cuff deflated, inspiratory air is going to be allowed down through past the deflated cuff. And on expiration, the expiratory air is going to pass around the tracheostomy tube up through the natural airway, or the expiratory air is going to pass through the bottom of the tracheostomy tube and then out through the fenestrated inner and outer cannulas, allowing for phonation to happen because you have that speaking valve keeping expiratory air from passing out through the tracheostomy tube. So let's look at this image, and let's say we inflate the cuff on this individual. Inspiratory air is going to be able to pass through the speaking valve into the tracheostomy tube. It's going to be able to pass down through the fenestrations into the tracheostomy tube. It's not going to be able to sneak around the inflated cuff. And then on expiration, that air is not going to be able to sneak around the cuff, that expiratory air, and it's not going to be able to push out through the speaking valve, so it will all be directed up through the fenestration past the vocal folds, allowing for phonation to happen. So there are some situations that are where a speaking valve is counterindicated. If there is some upper airway obstruction, meaning that air cannot pass from the larynx out through the pharynx and oral cavity, then that would be extremely counterindicated, because the patient would inspire through the speaking valve and then not be able to expire through the upper airway, through their natural airway, and also not be able to expire through the speaking valve due to the nature of the speaking valve. You would never put a speaking valve on a laryngectomy patient. Why? Because there is no natural airway. You put that speaking valve on there, then they can inspire, and that speaking valve opens and closes, and they can expire, and they have no other way to push air out, so you have sealed their airway. If a patient has a lot of excessive secretions that could maybe build up around the tracheostomy tube within the larynx, then they could inspire through the speaking valve. Speaking valve closes, and all those secretions could be sealing off their expiratory pathway around the tracheostomy tube. So you would want to be sure that you avoid that. You also want to be wary of foam cuffs. And so looking at this tracheostomy tube, that is a foam cuff. The foam cuffs are larger than the air cuffs, which allow them to create an effective seal within the trachea with less pressure on the trachea because of their greater surface area. And even when you deflate it, it occupies more space between the trachea and the tracheostomy tube. And that can be a negative thing for expiration, especially if the tracheostomy tube is not fenestrated. Well, first of all, think about the foam cuff. It is the foam that inflates the cuff. So you can suck the air out and you can vacuum the foam cuff down against the tracheostomy tube. And let's say you put a speaking valve on the patient and they are able to expire past the foam cuff. But let's say that vacuum seal is broken on their foam cuff, and suddenly you have a patient that has a speaking valve placed that they can only breathe air into, and now with the vacuum seal on that foam cuff broken, it starts to inflate. And it will seal off their expiratory pathway because they can't expire through the speaking valve. And when that thing inflates by accident, perhaps, they're not going to be able to expire past the cuff. And you have to think about the placement, careful placement of speaking valves on anyone that has some end-stage respiratory illness, because it is going to possibly make respiration more effortful. But it is nice that even if it does fatigue the patient that is at a late stage in their respiratory illness, they can take the speaking valve and place it for a period of time and be able to speak for a period of time. So for instance, like when they have visitors, and then when the visitors leave, they could take the speaking valve off and not have to worry about it.